Bismillahirrahmanirrahim. This is the third ever symposium in line of universal healthcare, which is being organized by KEMC, that is KE Medical College Alumni, UK, and King Edward Medical University. I'm going to introduce Dr. Shahid Bashir, who is going to moderate this session. He's our co-chair as well here from UK. He is consultant histopathologist at Salford Royal Hospital, Manchester, and have got special interest in breast pathology. He graduated from King Edward Medical College in 1984 and have had PhD from Southampton and a Farsi path from UK. Dr. Shahid, please take over and introduce our chairs, and we may officially open this webinar now.
Thank you very much, Dr. Zeeshan. Can I just welcome everybody to the third Universal Healthcare Symposium organized by KEMCA UK. We have 4 concurrent sessions running at the moment. This particular session is on infection and vaccination. The section is chaired by Mr. Chair-Naeem Majid, who is the technical focal person for routine immunization, and also advisor to Wish2 Action, and is also on the visiting faculty of the CPSV Karachi. My other co-chair is Dr. Saira Afzal, who's the Dean of Public Health and Preventative Medicine at King Edward Medical University. The session that we have will be split into 2 sections. The first section is on COVID-19, and we have 2 speakers on that topic. And the second half of the session will be on hepatitis C. So can I just introduce the first speaker, who is Dr. Zafar Yasin, who by profession is a physicist, and he is the Alice CERN coordinator and deputy team leader of the Alice experiment from the Pakistan Institute of Nuclear Science and Technology. We will have a question and answer session at the end of the first 2 talks. So if you have any questions and answers, please submit them via the question and answer tab at the bottom of your screens. And we will have a 10-minute question and answer session after the first 2 talks. So can I ask Dr. Zafar Yasin to start his presentation, please? Thank you.
Thank you, Dr. Shahid Bashir, for a nice introduction, and also for invitation to deliver talk on COVID modeling on this nice symposium. Can you please see my slides?
Yes, yes, I can, yes.
Okay. So I will present COVID modeling simulation results from Pakistan. So the outline of my talk is importance of modeling and simulation, and a simple SEIR model for modeling infection diseases, and then SEIR model and GLEAMviz model, and then modeling first and second COVID-19 in Pakistan using GLEAMviz and Profit, and then summary and conclusions. So modeling and simulation are used in every field of science and technology, in physical sciences, in biological sciences, in medicine, in economics, in mathematics, and in engineering, in epidemic, and in banking. Just 2 examples of the use of modeling. You can see on the left, there is a modeling using is simulation package for positron emission tomography for the dose of a patient on the left, and then the measured data from the PET. So we can see a good agreement between the simulation and the measured results. And on the below figure, there is another modeling from the CERN of an accelerator machine. This gives the fluence or dose distributions in an experimental hall. So about COVID modeling and simulations, COVID modeling and simulation is used by all the governments and by World Health Organizations in deciding on the best strategies to pursue in mitigating the effects of COVID, and then for timely and effective measures to be taken, and then to understand the spread of disease and to estimate the potential future burden on healthcare systems. And also COVID modeling is used to know the impact of different interventions like quarantine strategies and case isolation, then start and end of lockdown, and then social distance measures and the effect of use of masks. So different models are available for COVID modeling, and the famous are SIR model, and SEIR model is an extended version of this model, and then modified SEIR model, and these are the basic model used. And here in the present work we have used the modified SEIR model, and then there are other models like stochastic transmission model, and then agent-based network models, and then there are artificial neural networks. Simulation results are only the approximation of real-world scenarios. So I just brief about the SIR model. In SIR model, the total population is divided into 3 subsets like susceptible, infected, and recovered. And then susceptible person contracts the disease by coming into adequate contact with an infected person. And then from susceptible, it goes, the persons are infected by the proportion beta IS, and then when infected, they are recovered from the proportion of gamma I. These are important parameters, beta and gamma, and these parameters are sensitive and need to be determined for the virus. And their ratio is more important, beta or gamma or not, and it is called the basic reproductive number, and it is used for different countries with small different values, basic depending on the local conditions. R0 corresponds to the expected number of new cases from a single infection, and a small beta decreases infection and an increase in gamma increases recovery. We can decrease beta by staying at home, closing borders, observing hygiene, and developing the vaccine. The increase in gamma is triggered by better medicine and improved care of the patients. The most popular model used for describing the epidemiology is the well-known SEIR model, and it is susceptible, exposed, infectious, and recovered. Frequently used at population level to describe the proportion of the population in each state at any given time. So we have used a modified time-dependent, susceptible, exposed, infected, recovered meta population transmission model, and it is implemented in the GLEAMviz software. And it consists of different apartments, and here we have modeled the 7 apartments. The block diagram is shown on the right, and the susceptible are the total susceptible individuals. Then the other compartment is latent non-infectious, and then pre-symptomatic infectious are the individuals who are infectious but show no symptoms so far. Then mild symptoms, individuals with mild and asymptomatic cases. Then severe symptoms, individuals with strong symptoms and are supposed to be quarantined. Diagnosed are the individuals with confirmed diagnosis of COVID-19, and then recovered individuals who either got recovered or died. So here are the results from, on the right are the results from our model, and these results are for the first wave, and these were publicly available since 7th of June, and our predictions were in good agreement with the actual data. On the upper curve, there are cumulative cases in Pakistan until September 2, and then on the below graph are the daily cases of Pakistan until September 2. And for the modeling of the simulation, the first case was started from China, Wuhan, and we have first we have the benchmark this model for different countries in Europe and other regions, and it was working well. Then we have used this model for Pakistan with tuning of some parameters. And then we have some more results that are not publicly available, and these are also with some more parameters, and these are also until September 1st. And we can see the average cases around 284,000, and the daily cases around 5,000. And then we have this modeling from use this model for second wave, and we have predicted the results until first week of January 2021. And on the left sides are the cumulative cases in Pakistan, and on the right hand side are the daily cases in Pakistan. And we can see
Yasin, we have 4 more minutes.
Okay, so we can see the cases are rising. So we have also used another software called Facebook Profit for modeling and simulation, and the results from this are on the right hand side. And these results are also for Pakistan, and we can see comparison of actual data with GLEAMviz model and Facebook Profit model, and the results are in comparable agreement for those. So we have also simulated the results for 4 provinces in Pakistan, and prediction shows that the more cases will be in Sindh, and then in whole Pakistan cases can reach into 500,000. So this is also comparison of different provinces with the profit softwares, and the results from GLEAMviz are still under progress. And we have summary and conclusions, and then message to decision makers. Careful selection of parameters based on the local conditions could model the epidemic in Pakistan. The predictions of COVID-19 modeling using GLEAMviz and Profit for Pakistan are in reasonable agreement for first wave of Pakistan. GLEAMviz predicts the peak around first week of January, and Facebook Profit around 5th of December. Need to increase daily testing capacity. We are not forecasting a future, but rather a range of outcomes that we believe are more probable given the scenarios tested based on the data observed so far and our model assumptions. These forecasts are best considered as helpful guides rather than definite maps. Decisions to implement social distance measures and wearing of face masks should be made by at government level, and general public needs to follow the SOPs. And this is my message for the general public: to overcome this disease, they need social distancing, need to following the SOPs by the government, wearing a face mask, and balanced diet to increase immunity. There is just one example of wearing a face mask in US that is published last month in Nature Medicine. And if the 90% of the population wear the mask, then they can reduce the cases up to 129,574. So thank you for your attention.
Thank you, Dr. Yasin. A very wonderful talk. We will have a question and answer session at the end of the second talk. So please bear with us while we go through the second talk. Can I request all participants to submit their questions to the Q&A tab at the bottom of your screens, please. Thank you again, Dr. Yasin. Thank you very much. Can I now introduce our next speaker, Dr. Assad Hafeez, who is the Director General of Health in the Federal Ministry of Health and the Health of the Health Sciences Academy. And he's Dean the Faculty of Medicine at Quaid-e-Azam University. He'll be speaking to us about the readiness of Pakistan for COVID vaccines. Dr. Hafeez.
Good morning, good afternoon, and good evening to everyone. Thank you very much for this introduction. Let me just briefly correct that I used to be the Director General of Health, but now I am working as Vice Chancellor of Health Services Academy.
Right. Okay.
I'll be taking you through, after a very complex subject, a rather lesser complex subject of vaccine and our preparedness for vaccine. I would like to thank the organizers for giving me this opportunity. And let me now struggle with technology if I can share my slides with you. And if I cannot, then I would request, I think I'll request, yeah, I'll request you to kindly share the slides and I'll take it from there. Is it possible, Dr. Zeeshan? Yeah, that's fine. So can you see the slides now? Okay, so what I'll be doing is I'll give a brief overview of the global situation and where do we stand today. Can I have the next slide? And then I'll spend more time on options for Pakistan and the readiness and deployment plan, which we have and the progress till date. As I understand, that's the topic of interest. Could I go to the next slide? Right. As we know, there are a number of vaccines being tried for preclinical and experimental stages, whereas about 50 plus vaccines have now entered human trials, out of which by and large about 11 have reached phase 3. And some of them have got emergency authorizations in various countries, and we'll come to it in a while to explain what are emergency authorizations and what are regular authorizations or approvals, which till date there is none. It would be interesting to know that some newer technologies have also been applied as in lieu of oral or injectable vaccines, skin patches and electrical pulse devices. Similarly, researchers are also using non-spike proteins and tobacco leaf vector. These are some of the innovations which may come into visibility a few months down the line. So it's a continuously evolving scenario in which newer technologies and older technologies are being tried out. And we're likely to have 2 waves of vaccine. We're seeing the first wave. Down the line, 4 to 6 months down the line, we might see a second wave of vaccines, which would be more robust and better tried out with the new technologies and better immunities. That's what the perception is. Next slide. Can I have the, yeah. So primarily there are 3 or 4 platforms which are being used currently. One of the most popular one, or which has the largest number of vaccines, is the viral vector vaccines. We also have messenger RNA vaccines, inactivated virus vaccines, and then perfusion protein vaccines. There are others, but these are the common ones. The most talked about vaccine from UK is Oxford University's AstraZeneca, which is in the final stages of declaring their results. Then closely following are Janssen & Janssen from USA, Russian vaccine Sputnik, and CanSino, which is Chinese vaccines. So all of these are in phase 3. Novavax, another very promising vaccine. It's a perfusion protein technology, would be following soon, and they are in their phase 3 trials. Next slide. Then we have Moderna and Pfizer, which have already got their limited use authority from FDA and other countries. And in fact, currently the available most commonly used vaccine now as of today is Pfizer's vaccine. We also have inactivated platforms, not yet seeing the light of the day, but Chinese and UAE and Bahrain government are using Sinopharm in a limited way. Similarly, Sinovac is another phase 3 trial vaccine. India has produced biotech in which Bharat Biotech has produced a vaccine which is about to start its trials. And then Australian vaccines, it's an altered version of BCG. Next slide. It's important to note that the potential for next year is about 10 billion doses of the entire vaccine industry, and a large majority of it has already been pre-booked. Next slide. I don't maybe need to dwell a lot on this area, as I understand the audience is a very, very educated audience, but we do understand that safety and efficacy are two very important areas. Efficacy is derived from phase 3 trials, in which we, as we hear, Moderna and Pfizer are about 95% efficacious, whereas others have a claim of 70 to 90%. And some Chinese vaccines, Sinopharm, have claimed 86%. So there is a difference between claim and actual existence of efficacy. That's what the regulators actually find out. Sometimes phase 4 trials are also required, but that's once it is introduced in the market, they carry on from there. Till now, luckily, fingers crossed, no serious side effects of any vaccine has been noted. So once these vaccines are developed, then either stringent regulatory authorities need to register them, or WHO needs to pre-qualify these vaccines. Next slide. Resources are a major issue, and it's an evolving situation. There are three main resources from Pakistani perspective, and we would be talking a bit more detail on this. It's COVAX, Government of Pakistan, and others are for us, for Pakistan, we're trying to put together these areas. More than half of the cost component is the vaccine cost itself, whereas resources are also required for cold chain, operations, media, development, and some other monitoring and evaluation and other stuff. So this in totality forms the required sources. Next slide. As I mentioned, regulators have a very important role, and they are the last step to verify that this vaccine is useful. And then there are pressures, and then there are politics, and then there are so many other things which regulators have to go through. But for Pakistan, Drug Regulatory Authority has to approve any vaccine being used in Pakistan. So that would be the last hurdle for us. Next slide. We already have a lot of anti-vaxxers. So a very robust communication strategy is required before we launch in Pakistan, or for that matter, in any other countries. You are more aware of this kind of issues than me. Next slide, please. So what options do we have in Pakistan? There are two main options and a possibility. Bilateral contracts are Government of Pakistan's contracts with manufacturers. There are 8 manufacturers which are in the lead. And the issue with this is that it has a risk involved in it. Most of the contracts have to be advanced bookings in which monies are paid to get the bookings. And if that vaccine doesn't fly, generally the manufacturers have these conditions, then that money goes, it's no more available to be returned. So this risk is involved wherever we do bilateral contracts. COVAX is a window produced by Gavi and WHO with the help of many wealthy countries and donors, which has, for Pakistan and for many countries, they have now committed that they would give 20% of our population vaccine coverage in 2021. So that comes to around 45 million individuals for Pakistan. However, it is still in evolution. There are some issues with it, but it is a very strong, likely possibility for our country. A third possibility is private sector. It has its nuances and it has its pros and cons. But any vaccine which once registered by DRAP can be imported by private sector if allowed by the government. In all this options category, timing of making the right decision is very important. We can either wait and see for the best vaccine to surface, or we can put our bets on 3 or 4 vaccine manufacturers who we think as you know, as a country, that these are our best bets, but that has a risk involved in it. So it's a very tricky business to manage. Next slide, please.
Dr. Hafeez, we have 5 more minutes.
Sure. So Pakistan has put in place, considering the complexity and the issues involved with it, the government has put in place many mechanisms to look at the issues of vaccines. And for this, there is a National Vaccine Task Force, which is chaired by SAPM. There is an interministerial committee this is a cabinet committee, which is comprising of 5 ministers who actually oversee all the decisions. And then we have at technical level, a national expert committee, a vaccine negotiating committee, and an expert committee in DRAP to look at the data. So this is how we maneuver our way through this complexity. Next slide. This is the overall approach, and I'm being very, very brief. The first option is, of course, the first issue is selection of correct option, for which we have developed some mechanisms. Then overcoming the regulatory impediments, DRAP and others, funding and early procurement, effective logistics and vaccine administration planning, and finally, a sound communication strategy. These are linked to each other. These are not serial, but parallel activities, but this is how the government is approaching the vaccines. Next slide. So this is the prioritization criteria which the committees have developed for selecting a vaccine for Pakistan, including safety, efficacy, the cold chain requirements. Cost is a primary component, production capacity of the company which is dealing, and then the earliest vaccine availability for Pakistan. So these 7 criteria are ticked whenever the final selection is being made. Next slide. This is the target population which has been decided for the first 2-3 stages. And then as the vaccine availability increases, it would further be refined. The first one to get a vaccine in Pakistan would be frontline essential workers, followed by population over 65 years, then 60 years, and then probably those with comorbidities. And this vaccine supplied by the government of Pakistan would be free of cost for the recipient. All costs would be borne by the government and its resources. Next slide. So the most important thing is how do we, once we get the vaccine, how do we actually deploy the vaccine so that the access is equitable and everyone gets the right amount at the right time. So it is overseen in totality by the cabinet, which of course is chaired by Prime Minister himself. And then there's a cabinet committee, which is called NCC, which is a smaller committee, which specifically deals with Corona and its related aspects, in which Prime Minister and all chief ministers are involved. The operational arm of NCC is NCOC, that is National Coordination and Operation Center for Corona. And then in the ministry, we have smaller components, step-down components, starting from national focal point to provincial focal point, district focal points, and then in each district, there are focal points of health facilities, which would then be responsible for the local micro-planning. Next slide. It is the responsibility of expanded program of immunization, which would maintain the supply chain, which is on the specific responsibilities are on the left side, starting from international procurements to logistics, storage in cold chains, then further transport to provinces and districts, and then tracking of vaccine through MIS system. These are all responsibilities given to the existing EPI program, which is expanding, is already in the process of expanding its cold chain and getting itself readied. Now, the vaccine administration is primarily the responsibility of, and I'm talking of this vaccine which would be provided by the government and which would be free of cost. This is a provincial domain, and the provincial governments, in collaboration with the federal mechanisms, would put this mechanism in place. There is a bit of detail in it, and we are making use of NADRA, RMS, the existing system of registrations for families and individuals, which NADRA has tried down very adequately in different categories. For example, in Assad's program, the mechanism we are trying to follow is that each NIC number, let's say those above 65, would be picked up by NADRA. They would be enrolled. They would be sent a message through electronic means, with the SMSs through mobile phones, and a unique ID number would be given after verification. That unique number would be taken by the individual to the nearest facility, which would be indicated that which facility is allocated for him or her to be vaccinated. And there, once that individual is verified with the unique ID number, vaccine would be administered, and it would be followed up for further month or so for second dose. This is for those individuals who are in the system. There's an alternative system for those individuals who are not captured by this system. So nitty-gritties are quite complex, but this plan is almost in the final stages, and is being would be piloted in a few districts before it is rolled out. Next slide. I had been very brief on this plan sharing, but if somebody needs to ask more questions, I am available. So let me conclude by saying that safe and efficient COVID-19 vaccines are now a reality. The quality and efficacy of available vaccines would keep on improving with shifting goalposts in near future. There would be second wave or third wave in times to come. And it's important to realize that though the scientists have completed the arduous task of developing a reasonable quality COVID-19 vaccine, it is now up to managers, leaders, and politicians to ensure equitable distribution among the global population. May it be the world or a country or a province or a district, the responsibility is now well distributed on these specific individuals. Next slide. So from Pakistan's perspective, it has to carefully choose between available options, keeping in mind timeliness, resources, safety, and efficacy. And this process is quite ahead now. Adequate systems have been put in place to address these issues in a systematic manner. The vaccine deployment plan has to be flexible, considering the multitude of uncertainties and still many moving parts in the machinery. So we have to be very flexible and update our plan. For example, if we come to know tomorrow that it would be a 5-vial vaccine rather than a 10-vial vaccine or a single vial vaccine, the whole logistics have to be adjusted accordingly. And that flexibility is inbuilt in the deployment plan. And finally, Pakistan is poised to receive the first tranche of vaccines in Q1 of 2021, inshallah. And it would be distributed as per the shared plan. So I think I'm well within time, and I'll stop here for any.
Thank you very much, Dr. Hafeez, for a very thorough talk on the subject. Can I just share some of the questions that we've had online? The first question is there a Pakistani vaccine, and at what stage?
You want to answer me one by one? Or?
Yeah, if I could ask you, one of the questions that's been posted is that, is there a Pakistani vaccine, and if so, what stage?
Okay, Pakistan is not into manufacturing of vaccine as yet, though it has been realized now very strongly that we should be going into this area, and probably in the next few years we would. But at the moment, Pakistan is not manufacturing or producing any vaccine.
Right, thank you. Can I also ask something else related to COVID-19 in Pakistan? The published mortality figures for COVID-19 deaths in Pakistan seem on the face of it to be on the low side. I mean, compared to the UK, where we have about 67,000 deaths and our population is probably 1/3 of Pakistan's population. Published figures in Pakistan are in the region of 8,500. Could you comment on that as to why that is?
That's a very interesting question, which we have been asking ourselves for the last 4 or 5 months. And now, after 6 months, I can very confidently say that these are, if not 100% accurate, they are pretty close to what the actuality is. There are various reasons for why I'm saying this. There were a number of smaller studies carried out in different hospitals and in cities, including graveyards, comparing the number of deaths, the total number of deaths this year vis-a-vis last year. So from the available records, we found out that there's not much of a difference. Rather, interestingly, there has been some decrease. So as you know, graveyard, there are many major graveyards, and the burials eventually, whatever the cause is, can be recorded from graveyards. We picked up a similar kind of data from hospitals. And again, there was some differences, but that are explained in a different way, that some of the deaths like, cardiac mortality, accident mortality, they decreased. Accident mortality was significantly decreased. So, and then we did some modeling, and then we did some independent data and evaluations as well. And we're pretty confident, which is very interesting for us as well. But these figures, I, for one who has been dealing with such statistics continuously for the last 6-7 months now. On the one hand, we were also involved in modeling, and we ourselves predicted a large number of deaths in the first wave. Yes. But we are surprised to see that actually that did not happen. So coming back to your question, yes, it is interesting, different, but we think it is the right estimate.
Is it to do with the fact that population-wise, Pakistan has a younger population, and the lifestyle of most people in Pakistan is to live in a more open environment? Houses are open, there's more ventilation. Living is predominantly, a lot of living is outside rather than being within confined rooms or within confined public spaces. Does that explain part of the reduced mortality that we have in our country?
Yes, I mean, I would agree. We could have a long debate on this, that what could be the reasons, but obviously these are some of the important reasons, and primarily it is the age pyramid which we have in Pakistan. And in our existing deaths, out of these 8,500, about 75% plus are above 50 years of age. Yeah. So majority of them are from 60 to 70. Then above 70, we do not have a lot of individuals. For example, above 65 years, we only have 4.8% of our population is above 65, which is very different from what you see in UK and developed countries.
Absolutely. Thank you very much. Any more questions?
May I have a question from Mr. Zafar? Zafar, do you have any modeling done for the second wave? And people have been commenting on that the peak is expected in somewhere around mid-Jan. But clinically, what we are seeing in the hospitals, the pressure has suddenly gone down in the last 3 or 4 days of admission. Though we do hear a lot about the spreading of infection, but the seriousness of the illness and the pressure on ICUs for admission has gone down for surprisingly. Could you explain this trend with your modeling?
Yes, Dr. Zeeshan, like I mentioned in my talk, we have used 2 models. Our FB Profit model is predicting the peak on 5th of December that has passed. And our GLEAMviz model is predicting the peak in 1st or 2nd week of January. So we are still working on that, and we are trying to understand why the two models are predicting different results.
Thank you very much for your questions. Can we move on to the next session? And can I introduce our next speaker, who's Dr. Graham Foster, who's the Professor of Hepatology at Queen Mary University of London, and is the clinical lead for hepatology at the Baths in London. He's also the founding president of the British Viral Hepatitis Group, and he'll be speaking to us about hepatitis C eradication by 2030, insights for Pakistan. Professor Foster.
Thank you very much indeed, and thank you for inviting me. It's nice to hear some success stories from your COVID data, and I congratulate you on the modeling and your control of the epidemic and control of the mortality. So let's hope we can transfer some of that success to the other C virus, the hepatitis C. So these are my conflicts, and this is what we'll cover. You have two hepatitis C talks this morning. I'm going to focus on the virological aspects and leave Professor Qureshi to talk a little bit more about some of the distributive and political issues. So I'm going to talk about genotype 3, our treatment choices, and just a quick word about post-treatment. So let's begin with the genotype 3, the Asian subcontinent virus, which is, as you well know, very prevalent in Pakistan. And I think it's worth highlighting right at the very beginning that this is a very different virus. If you look at this map of genotypes with, on the same scale, hepatitis B and HIV, you can see that genotype 1 and genotype 3 are much more different than any of the variants of HIV and hepatitis B. This is a huge variation, a huge difference, and in fact, in other circumstances, you might even call these different viruses. So it's very important to remember that the virus you're dealing with in Pakistan is not the same by any means as the virus we're dealing with in most of Europe and the United States. And genotype 3 breaks into two different viruses. And the first is people without cirrhosis, where genotype 3 is a real pussycat and it's easy to treat. And we learned right at the very beginning that genotype 3 with interferon, old-fashioned interferon and ribavirin, was cured in 80% of cases. But the moment you move into a patient with cirrhosis and genotype 3, this virus changes into a real tiger and becomes much more difficult to treat. And we can see that very clearly in the Sofosbuvir trials. And Sofosbuvir, as you know, is a nucleotide analog. It's a very powerful inhibitor of all genotypes of hepatitis C. But it doesn't work well on its own, and it needs a friend. And the problem for genotype 3 is that there aren't that many good, readily available friends for Sofosbuvir. This is the very early data. You're all very familiar with this trial, looking at Sofosbuvir plus ribavirin for 24 weeks. Bear in mind that's a long treatment course, and you can see immediately that the non-cirrhotic patients respond very well. But the moment you have cirrhosis, things get very difficult and much more challenging. And that really is the hallmark of the genotype 3 story. Here's the boson trial looking at interferon and Sofosbuvir and ribavirin. I think this is a trial that may well turn into a more widely used treatment. And I know that my very sophisticated audience are gasping in horror at the thought of going back to interferon. Let me tell you that in the UK, we have already started 2 patients on Sofosbuvir plus interferon-based regimens over the last few weeks. They're patients with very progressive disease who have failed all of the available all-oral therapies, and we're going back to interferon because it's all we have left. And they're post-transplant patients with very aggressive disease. They're getting interferon plus Glecaprevir plus pibrentasvir plus Sofosbuvir plus ribavirin. So we're throwing the kitchen sink. And that does tell you that even in an environment where all the drugs are available, and even in an environment where we can monitor patients and insist on compliance, there are still patients with genotype 3 that we struggle to treat. And I don't think at this stage we should be discounting using pegylated interferon as a rescue therapy, because it doesn't cause resistance, and it may yet turn out to be required for that very, very small number of people who don't respond. That's not for one moment, Mr. Chairman, to suggest that I like interferon. I don't. I was very glad to see the back of it. I really hate ribavirin. It's a very troublesome pill to give. It lots of side effects. But I think it's just worth bearing in mind that if we fail first time, we may yet end up with these treatments. And I do warn patients with genotype 3 that this is the virus that requires very strict adherence to the medication, because it is tough to treat. And this, of course, is our favorite regimen for genotype 3. This is an interferon-free, of course, much, much, much better. This is sofosbuvir Glecaprevir, and you're very familiar with this combination. You can see that for 12 weeks, just about everyone without cirrhosis will be cured, but the cirrhotic patients do a little less well. You can improve that by adding in ribavirin. You can improve that by extending the treatment here to 16 weeks. Most of us would now opt for 24 weeks of sofosbuvir, Glecaprevir, and ribavirin, and expect to see a good treatment response. But the trials suggest that in cirrhotic patients with genotype 3, it's not perhaps as good as we would wish. And when you get to patients with advanced cirrhosis, patients with decompensated disease, and this is data from the UK study treating patients on a transplant waiting list with SOFDAC or SOFDAC ribavirin, you can see the response rates really are pretty disappointing in the 70% mark. So if you have patients with decompensated cirrhosis and genotype 3, the success rates are poor, I'm afraid. They're down in the 70% mark rather than the 80 to 90%. So the message for SOFDAC is very clear. Get your patient treated early. If they're non-cirrhotic, you've got a guarantee of success. If they're cirrhotic, it's tricky. If they're decompensated, it's very tough indeed. So this is not yet the perfect treatment for genotype 3, I'm afraid. Of course, the trials were done in Western patients. These are predominantly ex-injection drug users. They're predominantly people with addiction problems and alcohol abuse. It's a very different cohort to the people that you're treating in Pakistan. And the good news is that the type of patients you're treating are responding much better. This, I'm afraid, is an Indian study. This comes from the Indian Punjab. You can see the numbers here are huge, so it's a real-world study. And I've highlighted at the bottom the SVR data of over 90% in both non-cirrhotic and cirrhotic patients. And I think this is a reflection, firstly, on compliance. I think people in Pakistan do better with compliance than the patients that I normally look after. I do think compliance is very good, which is helpful. I do think the Pakistani, the Indian communities seem to respond a little better to these treatments than the Western communities. Maybe that's because of cofactors, obesity, alcohol, etc., but they do pretty well. So this sort of data convinces me that elimination in Pakistan is very doable and very achievable. Is that going to be enough? Curing 90% of patients is fantastic, but of course, if you start with 20% of your population infected, and there are some parts around Karachi where those are the levels, that means you're still left with 1 to 2%. Will we see a second hepatitis C wave? I think that's a really important question. You'll be pleased to hear that with Huma Qureshi and colleagues at Aga Khan and Dow University, we're running a very large Wellcome Trust funded trial that will start in the new year, asking exactly this question: what proportion do we need to cure to eliminate hepatitis C? Because of course there are alternatives to SOFDAC. They're more expensive alternatives. This is Sofvel. You can see in the patients who are cirrhotic and treatment experienced, it's not quite as good as we would like. So we still don't have a solution to hard genotype 3. One option, of course, is to throw the kitchen sink at it. This is to add 2 friends to sofosbuvir. This is the SOF-Velvox trial. You know the results. They're very good indeed. And indeed, they're very good in the cirrhotic population, which is why EASL still recommends that for cirrhotic genotype 3, triple therapy should be considered first line. We don't do that in England. We think that's too expensive. I suspect that will be far too expensive for Pakistan. But it does highlight again this important point: get these people treated before they have cirrhosis, because that's when you'll get most effects. Because once you're cirrhotic, it gets a bit tricky. There are, of course, some new options. These options are becoming more widely available. I'm disappointed that the manufacturers didn't make generics of these drugs available much quicker, but I think that is now being put right. And this is Glecaprevir, pibrentasvir. Very effective in genotype 3. You can see here in non-cirrhotic patients, non-cirrhosis, 8 weeks is enough. Here's a 12-week cirrhosis study, and again, very good response rate. So this combination looks pretty good. We use it a fair amount in England with great success. It's well tolerated, a little bit more expensive and a little bit harder to make, so not quite as readily available. There is, as many of you will know, a move to use it for 8 weeks in people with cirrhosis. And this is the trial that justifies that. There's now a license change in England. I've got to be honest and say I'm nervous about this. I think if you fail to treat genotype 3 cirrhosis first time, you have a problem. And I highlighted that at the very beginning with some of the problems we're struggling with in England. So for me, I would rather give 12 weeks for cirrhosis. For me, I think a trial in 60 patients is not big enough to give me the confidence. So in my own practice, I tend to extend for 12 weeks with Glecaprevir, pibrentasvir in genotype 3 cirrhosis. And you can hear that I'm a nervous sort of man. I don't like to fail treatment in people with genotype 3 and cirrhosis because it's very hard to rescue. I don't want to finish without highlighting the importance of cancer post-cure. This is particularly important for genotype 3. Genotype 3 seems to be more oncogenic than the other viruses. It is really important that anyone with cirrhosis is offered 6 monthly ultrasound scans, because the risk of malignancy, I'm afraid, continues for up to 10 years. And we are still losing patients that I cured 5, 6 years ago from cancers that have been missed in the screening. Some of my patients are drifting away from screening. Some of them are getting cancers that are missed. So we do need to be very clear that the scanning must continue. So I'm going to leave you with an optimistic slide, because I do believe that this is a curable disease for most people. We don't quite know what is the perfect regime. Should we use SOFDAC for 12 weeks and then rescue people with triple therapy if they fail? Should we use triple therapy for cirrhotic patients? Should we try and use more ribavirin in the cirrhotics? There are interesting questions that still need to be answered. And I hope that the work that you and others and we are doing will start to answer those questions, because we do need a strategy to prevent failures in the cirrhotic population. And please don't forget that liver cancer surveillance does need to keep going. But whilst I've highlighted some of the concerns with the drugs that we have, please don't pretend that we are fighting against the drive to eliminate hepatitis C, because I think we can. I think it's important we don't let perfection be the enemy of the good. We've got great drugs. They're not perfect. I'm a perfectionist, but they're good enough and they will do the job we need to do. We really can make this do. And I think we should get out there and get on with eliminating hepatitis C in Pakistan, because I think it's very doable. And on that, I'll be very happy to take questions, and thanks for listening.
Thank you very much, Professor Foster. Could I just open it up to questions from the panel and from the participants, please?
Dr. Shahid probably will take the questions after all 3 talks. After.
Yeah, we can have the question session at the end of the 3 talks. Yeah. Right. Thank you very much, Professor Foster, for a wonderful talk. We will have a question and answer session at the end of this session. So please bear with us while we go through the other 2 talks. Can I now introduce Professor Qureshi, who's our next speaker. She's the Executive Director of the Pakistan Health and Research Council in Islamabad and the national lead on the prevention and control of viral hepatitis in Pakistan. And she'll be speaking to us about hepatitis C eradication. Are we on course for 2030 in Pakistan? Dr. Qureshi.
Hello, everyone. This is Dr. Huma Qureshi. I'm a gastroenterologist and I'm the national focal point for hepatitis. I shall be showing you the facts and figures about the hepatitis C eradication. Are we on the course for 2030 WHO elimination? Next slide. So this is the HCV prevalence in Pakistan, which was studied on the national level in 2008. And at that time, it was shown that the prevalence of hepatitis C was 5%. And this had put Pakistan as the second highest prevalence country for hepatitis C in the world. Later, Punjab did a survey in 2018, and they showed a prevalence of HCV of 8.9%. And then later on, a Sindh survey was also done in 2019, and that again showed a slight increase in the prevalence to 6.1. So you see that we still remain as the highest prevalence country in the world. Next slide. So the WHO targets for the elimination of hepatitis for 2030 are shown here, and you all know that for hepatitis C, the diagnosis needs to be that 80% of the chronic hepatitis C patients need to be diagnosed, and then 80% of these need to be treated, and then 90% of those who are treated need to be cured. Similarly, for the new HCV infections, there's a 90% reduction in the new infections and about 65% reduction in the HCV-related deaths. Next slide. So Pakistan has been fortunate to have the pan-genotypic generic directly acting antivirals, and these are cheapest in the whole world. So we have two combinations currently available with us. One is the sofosbuvir and glecaprevir, which is available at a cost of about $25 for a 12 weeks treatment. And then we have the valpartasvir, which is available as $120 per 12 weeks treatment. Next slide. We also developed our national hepatitis C testing and treatment guidelines in 2018. And the intention was that everybody should be treated, and the treatment should go down to the general practitioner level and not to the consultants and the specialists. So the algorithm is very simple, that we do the antibody testing for the HCV, and then those who are found HCV positive, they undergo the HCV RNA test. And then those who are found HCV RNA positive, they undergo further testing for CBC and AST to calculate their APRI or FIB-4 score. And this is calculated to decide the duration of therapy. And then they're given the DAAs, and then we check them again after 12 weeks of stopping the DAAs. So next slide. To address the huge burden of hepatitis C in Pakistan, the President of Pakistan announced the Prime Minister's program for hepatitis C elimination for Pakistan, and this was announced in 2019 on the World Hepatitis Day. And in this program, we intend to treat all persons who are more than 12 years of age, and they shall be screen tested and treated free of cost. Using a 10% prevalence of anti-HCV and a 70% positivity for the HCV RNA, we roughly calculated that we would probably need to treat about 15 million people. But this was just a very, very simple mathematical calculation that we did, but then we thought that we should have a more scientific calculation of this disease burden using the expertise of Homi Razavi from the Center of Disease Analysis. And he was requested by the federal government to undertake this modeling, which he had agreed. Next slide. So the Testing and treatment plan as of the Prime Minister's program is that we will screen using the rapid anti-HCV test at the rural health center. And then this would be followed by a nucleic acid testing, which would be done either at the tertiary care or a selected district headquarter hospital. Blood samples of the anti-HCV positive patients or cases would be sent for the nucleic acid testing. Patients will not move, the blood samples would go, and the reports will be sent electronically to the site from where the sample was sent. Treatment should also be dispensed from the same site, and the sustained virological response will also follow the same pattern as the blood. So this was made as simple as the one I have shared with you. Next slide. So then, as Homi Razavi was requested to do the modeling for us, which he agreed, and this was the modeling was started in October this year. Next slide. So this is a very important slide where I would like you all to please bear with me for a few minutes. And this is showing the current cascade of care for Pakistan, which was developed by Homi Razavi using our current cascade of care as of 2020. So you see that there are about 9 million anti-HCV positive cases in Pakistan. And if you see the red bar, these are about 7,348,000 people who are viremic as of 2020. So using the WHO's numbers and the percentages, about 80% of these who are viremic should have been diagnosed. But you see the red bar, and then you see over the blue bar, only 2 million or 28% have been diagnosed so far. So we are lagging behind the target by 62%. And then out of these 2 million odd patients who have been diagnosed, only 34,000 or 6% have been treated, as you see in the third bar. And again, here we are lagging behind by 84%. And out of those who have been put to treatment, almost 96% have been cured. You see the last bar. So this is the only cascade, leg of the cascade where we are on the WHO target of achieving the cure in over 90% cases. But of the rest targets, we are really falling behind. So apparently it looks that if we do one-time nucleic acid testing in all the cases who are antibody positive and then treat all who are nucleic acid positive, we can achieve the WHO elimination target by 2030. Next slide. So for the trends in the HCV incidence for Pakistan, this slide shows that if we do not do anything to prevent the new infections, the current trend of HCV infection will decrease automatically from 400,000 to 200,000 by 2030. But this would not help us achieve the 2030 target, although the number of new infections will go down, but still we need to do more. Next slide. Similarly, if we continue with the current standard of care, this slide is trying to show you what will happen. This is a busy slide, but I will take you through line by line. So remember that we had 7 million viremic cases. If you see in the first row, it is the number of cases who are treated, and these are remaining the same. That is about 434,000 from 2019 to 2028. So out of the 7 million viremic cases, only 434,000 or 6% are being treated yearly. And then you see in row 2, additionally 354,000 new cases are being diagnosed yearly, and they also remain same. So this slide is actually showing that if the status quo of whatever we are doing right now, if we continue to do the same for the next couple of years till 2030, the numbers of newly diagnosed cases and the treated cases remain the same. Then you see in the row 3, almost 4,000 new infections are being added yearly, and I told you in the previous slides that these new infections will automatically go down slightly. So you see the slowly going down trend by 2028. And in the last row, you see that the present screening of about 2.4 million people yearly, this also goes up automatically slightly, but with this trend, it is very unlikely that we will achieve the 2030 WHO goals. Next slide. So Homi has developed this slide for us, and this is what is showing that if we continue with the status quo of the testing, treatment, and the new infections, there is a 27% decrease in the total number of infections. Although we know that this is not adequate because we need to have it as 70%, which was set by WHO. There would be a 63% decrease in the liver-related deaths, as you see on the right-hand lower figure of the graph. The liver-related deaths go down by 63%, but as per WHO's requirements, it should be about 60%. And then you see the hepatocellular carcinoma. Right now we have a 50% decrease in the HCC, and this should be 60% as said by WHO. So again, you see that we are lagging behind in all these parameters. Next slide. So now if you look at the slide, this slide, which is the Ministry of Health or the Prime Minister's program, which is trying to reach out to all the populations of Pakistan. So the Ministry of Health or the Prime Minister's program it has been divided into two phases. In the first phase, which is from 2020 to 2025, 50% of the more than 12 years population, which is about 88 million, shall be screened, diagnosed, and treated. And from 2026 to 2030, we screen rest of the 50% population and add less than 12 years of age also. And this makes almost about 195 million population. So in the first row, you see that yearly we shall be treating about 0.5 million cases. In row 2, you see that yearly will increase the diagnosis from 354,000 to 948,000 by 2028. So there's a drastic increase in the diagnosis. And you see in row 4, we reduce the new infections yearly. And in the last row, you see that we screen 9 million cases in 2020, and this also goes up drastically from 9 to 12 million to 16 million and so forth. And with this target, we shall be able to, inshallah, achieve the required target of the WHO. Next slide. So using these numbers, Homi has developed these cascades for us, and it shows that we will be able to reduce the total infections by 1.9 million. We will save 2,800 lives, and we shall avert about 6,200 new cases of HCV, of hepatocellular carcinoma. Next slide. So this is again a very important slide for us because if you look at it has got this graph on the left. So in the black bars that you are seeing are the current numbers which are presently we are doing like testing and treating, and the red bars are the additional numbers that we have to do to achieve the WHO target. To date, that is till 2019, about 2.13 million cases have been treated. And additionally, 5.7 million patients need to be treated from 2020 to 2030. This means that 0.5 million cases need to be treated yearly. And this is what I showed you earlier, that the Prime Minister's program is also planning to treat 0.5 million cases. So we are almost on the same trend or the same numbers. And with this trend, we shall be able to achieve the treatment and the cure goals. For new infections, the current rate numbers is 23,000 cases per year, and this needs to go down to 75,000 per year to achieve the goal. And here, unfortunately, the Prime Minister's program is drastically falling short of it, and we have to really work hard to bring down these new infections. Next slide. So, ladies and gentlemen, this is my conclusion that with the present pace, the 2030 HCV elimination targets are difficult to achieve.
We have 5 more minutes.
For HCV, which got delayed because of the COVID, needs to be launched by 2021 because the time is short and we have to really work hard. Compared to the present pace, the screening, testing, and treatment has to be enhanced 8 times. And for the new infections, they have to go down by 5 times of the current pace or the current situation. And then obviously linking all the sites using the electronic data transfer and rigorous monitoring of the targets at the district, provincial, and national levels can help us to achieve these desired targets. And we need very strict actions on controlling the risk factors, which are like safe blood, safe injections, and infection prevention and control in the healthcare settings to achieve the targets. Next. And thank you very much.
Thank you, Professor Qureshi.
Hello, everyone.
Hepatitis.
This is Dr. Huma.
And we are on course for the 2030 targets. Thank you very much. Our next speaker is Professor Ghias Tayyib, who is the Professor of Medicine at Lahore General Hospital, and he's also the Dean of the Postgraduate Medical Institute. He'll be speaking to us about the hepatitis C eradication prospects and the strategy in the provinces and the country. Professor Tayyib?
Sir, you are muted. Kindly unmute yourself.
Okay, now can
Yes, we can.
me?
Yes, we can. Thank you.
Permit me to share the slides. Can you see my
yes,
slide,
we can.
please?
Yes.
Well, I'm really thankful to the organizers for giving me the opportunity to talk about hepatitis elimination prospects in Pakistan. You've heard Dr. Huma, she has projected the figures for Prime Minister program, which is expected to be launched next year. But lots of things have been happening in the past 10 years. So the hepatitis control program started way back in 1996, 97. And then at that time, because of the interferons and poor efficacy of the interferons, although the program was there, but the efficacy was limited. But then later on, the things changed as the things got better. This is my financial disclosure. I don't have anything to disclose pertinent to this, but since I've been a project director for hepatitis control program in the Punjab, and then I developed guidelines for hepatitis C this year. And then I've been member of the committee for which the chair, Dr. Huma, has just spoken to you on this issue. So what have we been doing in Punjab? We have been able to sensitize the people. We have been able to identify the things. We have been able to draft the solutions. And to some extent, we have been able to implement, although the challenges which have been set to eliminate hepatitis C in Pakistan are yet to be seen in real life and in real terms. And we all know that Pakistan is the second most viremic country in the world. And after a successful control in Egypt, we had a hope that we'll be able to achieve the same in Pakistan as well. China being the most populous country in the world, they have more number of hepatitis C patients. But then otherwise, in terms of percentage, Pakistan remains the most challenging country at the moment. You have seen this slide, though, in a different form, that we want to achieve 90% reduction in terms of hepatitis burden by 2030, and then 65% reduction of disease by 2030. And in terms of testing, treatment, harm reduction, blood safety, injection safety, these are the targets that we like to achieve in terms of prevention as well as in terms of control of the disease by 2030. Now, if we look at this cartoon, this is a very important message to us that Pakistan remains one of those countries where the testing and understanding about the prevalence of disease remains poor. That's less than 20%. And to be honest, not many people know about their disease status. No, not many people know about the hepatitis C status in their own self. And not to talk of the non-medical community, the prevalence patterns are not very encouraging in the medical community as well. Punjab, since Dr. Huma has spoken about Pakistan, I shall focus mainly on Punjab. And in 2017, the political government at that time, they started off with a very robust strategy by dividing the elimination program into three categories. Some chunk was given to the Prime Minister Secretary, and those who don't understand the Pakistani health system, Prime Minister Secretary Healthcare Department that looks after the Tehsil headquarter, district headquarter, and basic health units, meaning by that at least 80% of the healthcare industry is taken care of by this department, and they were given the assignment to build hepatitis clinics, and that they built in 130 centers. Then a tertiary or mega hospital was built at a cost of 25 billion Pak rupees, and part of the mandate of this Pakistan Kidney Liver Institute was, in addition to liver transplantation, in addition to high-end care of the liver patients, was to look after the patients in certain hepatitis clinics as well. And then special healthcare and medical education department, which is there to look after the needs of the autonomous medical institute, that is the medical education institute, for example, medical colleges and universities. They were given the mandate to develop not just the hepatitis clinics, but to develop the endoscopy suites as well as the gastroenterology units at the 17 medical colleges attached hospitals, so that the high-end care as well as the first care for the patients who are presenting with hepatitis may be provided to the people who are coming to the hospital. And let me tell you that the number of people who are coming to the teaching hospitals attached to the medical colleges is huge. And as many as 10 to 15,000 footprints are there on every day. So if we focus on these two, the primary and secondary healthcare and special healthcare, we should be able to come in contact with majority of the people, that meaning by that a major problem that we think that finding the missing millions and then going to the community, that is next step in terms of achieving the elimination. At least to some extent we can achieve that. This survey has been projected to you by Dr. Huma in her slides as well, but just to re-emphasize that hepatitis C, the survey which was done in 2008 by Dr. Huma herself, the figures in Punjab was 6.7%, but then in 2018 we know that the figures that we saw, that they were as high as 8.9%. And that is the strategy that we evolved in 2017. This was a four-pronged model to educate the people, trying to prevent the people for hepatitis C, and harm reduction in terms of eliminating all those factors which bring on the transfer of infection, and then testing the people and testing as many people as possible, the ones who come in contact with the healthcare workers, and then treating all those people who come in contact in phased fashion. This was a four-pronged model strategy that we evolved back in 2017. And for that, the legislation was done. I'm going to come down to the legislation, the very important legislation that was done in this context. Regulatory framework was developed, advocacy, communication, social mobilization models were developed, and then screening, diagnosis, and treatment through the hepatitis clinic, which were developed at 147 centers was developed, and then disease surveillance system was put in place. And this is an example of the disease surveillance system. And one component was an electronic medical record, where each and every patient and each and every activity which was done in Punjab, that was getting reflected in the form of registration, in the form of screening, in the form of vaccination, and similarly all other activities which are pertaining to the management of the hepatitis, they were projected. And this is roughly the figures as in of day for yesterday, the last working day of the last week, that in these 147 dedicated hepatitis clinics, 14 million registrations were done, and million screenings were made, and treatment of hepatitis was ongoing treatment of hepatitis B was 24,413. Treatment of hepatitis C was roughly about 3 million, and then vaccination for hepatitis B roughly for 6 million. So huge effort is being spent on this issue, and this is the legislative framework that I was talking about. That in Punjab, Hepatitis Act 2018 was passed, and this was a very robust document, and if implemented in its proper spirit, I think this can become a backbone of the whole activity. Robust surveillance in terms of case finding, screening, diagnosis, treatment, epidemiological study of hepatitis, and then use of auto-destructible syringes instead of those syringes which can be reused, restoration of the barbers and beauticians, and implementing the strict health policies in them through the healthcare organization, safe blood transfusion to all, and then similarly compulsory hepatitis B vaccination for all the newborns at the time of birth, the birth dose vaccination, healthcare waste management in its proper way, dialysis surgeries and organ transplant regulation through the HOTA and the other regulatory bodies, and testing of all the prisoners and high-risk workers. These were the major things that were included. And through this electronic dashboard, the ones who come in contact with the healthcare system, trying to find the missing million which are there in the community, trying to find those who come in contact with those patients who are actively suffering. That was planned through these 147 hepatitis clinics, and this is the activity has been seen in the previous slides. Now, diagnostics remains a very important subject. The far-off areas, the areas which are difficult to reach, one has to develop a facility in their near future. One model was to bring all the samples to the center, meaning by Lahore, but then that was cumbersome. Lately, the model has been developed to maintain the diagnostic labs at various teaching hospitals, which are spread all across the province, and then developing special facilities at the center, meaning by Lahore, and there are at least 5 available in Lahore and rest outside Lahore. Similarly, vaccination centers were developed, and at all the hepatitis clinic centers, that meaning by 147 centers, the hepatitis vaccination centers against hepatitis B were developed, and the hepatitis B vaccination was being provided to all. What is the performance up till now? Part of has been discussed with you in my previous slides, but few things which I like to emphasize, that the samples which are collected and the samples which are received, and then the results, they're all displayed in this EMR, and that helps us in managing the hepatitis related activity in all forms in the macro elimination. Now, how about micro elimination? Meaning by that, taking the care to the people. One project which has been discussed and which has been projected in this very meeting as well. My colleague, Dr. Shafqat Rasool, has presented his data in this meeting. And this activity was conducted in Nankana, where the micro-elimination program was taken to the doorstep of the people in 2 unions. The healthcare team of primary secretary people, they went there, they did the education activity, and similarly they tested all the people who were there, and those who were found positive, they were treated, and the hepatitis was eliminated from that society. These are the results which have been projected in the society. Now, how about the partnerships? The partnerships have been developed with the other NGOs, for example, Serve Foundation, Digestive Disease Foundation, and similarly the NGOs working in Gujranwala and Hafsabad area. Similarly, the partnership has been developed with the academic institutions, with the family physicians firms, and other department hospitals. And the hepatitis control program is working in close collaboration with all these 4 partners at various levels in order to eliminate hepatitis C by 2030. Advocacy groups have been developed. The advocacy groups have been there in the form of political and then in the form of intelligentsia with the academic institutes like universities. where the lectures are being conducted and the young people are being taught on the importance of methods how to prevent hepatitis B and C in the community, and similarly, if somebody is found positive, where to go and how to get themselves treated, and finally health journalists as well. So this is in nutshell the activity which has been done in the past 3 years in order to have a control in the hepatitis C. Thank you for your patient listening.
Thank you very much, Dr. Ghias. Can I open the forum up to questions from everybody, please? So if there are any questions about hepatitis C.
May I have a housekeeping announcement before we officially start with Q&A? There is a link in the chat which I have posted for all the audience there who want to claim the CPD points or CME points. Kindly mark your attendance in this link so that you can be offered a certificate with CPD or CME points. My pardon, and Shahid, you can continue with the Q&A.
Right, thank you. Any questions from any of these speakers or any of the attendees? Can I start off by asking Dr. Tayyab? Dr. Tayyab, do we sort of have a national screening program in Pakistan where the population at large is screened for the presence of hepatitis B or C, rather than patients who actually present to a clinic?
It's a very important question. Up till now, we don't have a screening program, meaning by that we are not going to the doorsteps of the communities to check the hepatitis C in each and every household. But right now, if I look at the figures and if I look at the statistics, I intentionally not shown one component of the activity. The number of people who are coming to the hospitals, they are huge, either in for getting themselves treated in the OPD or maybe getting admitted, and similarly deliveries. Footprints of an average hospital of 1,000 beds is roughly around 10 to 12,000 people every day. So even if we start checking them, still it's a good number, and the ones who get, we find them positive, we can do the contact tracing and we can go to their homes and take it on. And in context of that, let me share a few important things that up till now, we have been able to enroll 10 new patients in teaching hospital attached to the teaching hospital, hepatitis clinic attached to the teaching hospital. And we are enrolling 3 new patients to the hepatitis clinics which are there in the district of Tehsil Headquarters Hospital. Now there's a huge gap existing on this account that if in a teaching hospital, and we're talking about a population where the prevalence is 8.9% general, and in the adult population, roughly I should say that it goes up to 16 to 17%. So in a teaching hospital, if that many number of patients are coming and that many number of people are coming, enrolling just 10 patients every day, and similarly in a Tehsil Headquarters Hospital or District Headquarters Hospital where the average bed size is 350 to 500 beds. If we are enrolling just 3 patients per day, new patients per day, meaning by that still lots of efforts are need to be directed to bring the patients, the communities which are coming in contact with the healthcare workers and bring them, meaning by developing linkage to the care in the hepatitis clinic. So that kind of effort is needed first before we go to the before we start going to the community in the form of micro-elimination programs, which is going to cost us a huge amount of money. I don't know whether we do have that kind of money available to us. To be honest, I think that right now we're not prepared for the micro-elimination strategy. We need to concentrate on the macro-elimination strategies, and we need to concentrate on all the people who are coming to the healthcare facilities and trying to test them, and the ones who are tested positive, linking them to the care facilities.
Is there any room for testing all specimens taken, even for other conditions? I mean, in Pakistan, it's quite common to have blood tests done by the population in general. Is there a room for testing all samples taken for whatever cause for hepatitis?
Yes, the room is there, but obviously you need lots of funds for that. But to be honest, yes, we have the facility and we have the capacity to test the people who are coming to us in the healthcare facilities.
Thank you. One of the other questions that was posted online is that will the Nankana project be expanded to other areas?
Well, that's a very good question. But then it comes down to, you see, in just 2 unions, the amount of money that we had spent, and for one district, the projected cost is 1 billion rupees. So for 32 districts of the province, we need 32 billion rupees. Now, that's a huge amount of money. Even if we phase it out to say next 7 years or 8 years time period, still it is going to be quite a burden on the national exchequer. So theoretically, yes, it is possible, but logistically, in the post-COVID time period, will we be having spare funds for conducting this kind of activity? We've yet to see this thing.
Right.
I wish that we should be doing this.
May I add a question relevant to this to Dr. Ghias? Dr. Ghias, you have recently partnered with the project ECHO. Do you believe that this public-private partnership model, where the government have partnered with one of the NGO and mobilizing the local community and getting the funding from the local community, because we believe that philanthropy is at maximum across the world in Pakistan. There are a lot of philanthropists and they do help out the community. So would there be a role of private partnership?
Yeah, you're perfectly right in saying that Punjab Hepatitis Control Program is already partnered with the ECHO program. Dr. Assad Chaudhry in Gujranwala and similarly Server Foundation and the Registered Disease Foundation, these 3 organizations are already in collaboration with Punjab Hepatitis Control Program, and they're acting as partner. These 3 NGOs are working on behalf of Punjab Hepatitis Control Program in their own areas and providing treatment to the people, and not just the treatment, but education, testing, treatment, and prevention as well.
Thank you. Could I put up a question to Professor Foster? Professor Foster, would you comment on the strategy that Pakistan is adopting for elimination of hepatitis by 2030, please?
Well, firstly, I think I need to congratulate my colleagues, Dr. Tayyab and Professor Qureshi, who really have driven the Pakistani program and done a fantastic job. You are absolutely right. I think Dr. Tayyab made the point. You have to cut your coat according to your cloth. You have an excellent strategy. It needs resourcing, it needs funding. I think there are optimistic signs that new diagnostics will bring the price of testing down, and that will certainly help things, because if you can test more people for less, there are some very interesting new point of care testing devices that might be much cheaper, and that obviously takes out one of the hurdles of laboratory costs, etc. One hopes that the drugs will become cheaper with time. There's certainly been a lot of pressure on downward prices. But I think the overall strategy is exactly right. You turn off the tap by focusing on the high transmission events, getting blood transfusion services to maintain high standards, reducing reuse of needles, educating the public, reducing the barbershop transmission. All of those are very, very worthwhile things to do. And I think that they will continue to yield huge dividends for you. And then it's a question of testing and treating. And we've heard 2 very good talks on strategies to do that and to expand it. And I think that provided the political will is there, certainly the medical community in Pakistan are ready to step up to the challenge. So I have no doubt that your strategy is correct. I have no doubt that the people on the ground are the right people to drive this. Let us hope in the post-COVID world that the political will continue, because if it does, I think you have every prospect of eliminating hepatitis C.
Thank you. One of the other questions posted online is what PCR tests are being currently used in Pakistan?
This is basically a real-time PCR, Abbott or Roche. These are 2 machines which are being used in Pakistan, at least in Punjab at the moment.
There was a question, Dr. Ghias, if you could comment, I would add mine later, that why gene expert, that is the Foster was talking about, the point of care test is not being used now that Professor Huma have already joined us. She would also comment on that. Okay, why we are relying on PCR and the financial aspects of this testing versus the treatment. Supplementary question was the cost of supplementary question was there for the cost of treatment and cost of diagnostics.
Well, there are two important things that we must remember about Gene Expert. TV.machine, TV.program mediated Gene Expert machines are available in majority of the centers in the district and tehsil headquarters hospitals, and similarly in the teaching hospitals in Pakistan. The issue with the Gene Expert technique is that the cost is substantially higher as compared to the real-time PCR machines. The real-time PCR machine per patient cost is roughly about 1,350 rupees per patient. And on the contrary, Gene Expert cost is coming roughly to 2,500. We have tried to negotiate in the past with the Gene Expert company to give us at a reduced cost. Dr. Huma will be in a better position to update you on the latest developments on that account. But till such time that I was closely linked to the program, the Gene Expert was not willing to come down on their price. And I'm sure that the latest prices will be even higher. And then at the same time, the Gene Expert cartridge has an issue with the disposal as well. If we use the Gene Expert cartridge and to the numbers that we are projecting, do we have the capacity, and will the company take the responsibility to dispose of in a proper way all those cartridges? So although this was a secondary issue, but the primary issue was obviously the cost, because it's the cost. Anything which is more than 10% of the original or the previous practice, it is very difficult to implement in the public sector.
Never, you are right. He said the basic issue remains. The Foster wanted to comment. Yes, sir, Foster.
So I agree entirely with Dr. Tayyab that the manufacturers of Gene Expert have been very, very slow to bring their price down. I think one of the good things about COVID has been there's been a surge in new point of care diagnostics and companies. I've been involved with a German company, Blink, that produce a machine that will do 12 tests in 20 minutes, and they're hoping to have the whole 12 tests for a few dollars. Now, that sort of technology rolled out will change the game and force Gene Expert to bring the price down. So I think the one good thing to come out of COVID has been a revolution in point of care diagnostics that can be turned to hepatitis C. And I think that will change the game, because as Dr. Tayyab says, at the moment, there's only one player in town, and when you have a monopoly, they can charge what they like. We need to get some competition.
Okay, that's an excellent answer. And probably we have answered the question related to diagnostics versus the treatment cost. Definitely the cost of generics in Pakistan is much lower than what is there in the West, but we struggle with the diagnostics. We still have to rely on the PCR based on the comments we had both of the worthy speakers. Shahid, do we have any other question?
Can I just ask a question again? I mean, are any attempts being made in Pakistan to develop some of these point of care testings? I mean, Pakistan does have a molecular setup, and are there any private initiatives to sort of develop those systems within Pakistan?
Yes, there have been in the past. For example, in the Center of Excellence for Molecular Biology, they tried to develop the nested technique, and the cost of the PCR was much cheaper. It was roughly about 1,100 rupees per patient. But considering the standard of care and reproducibility, ultimately everyone settled to a Roche or Abbott machine. So Roche and Abbott machine is available in all the teaching hospitals in the teaching hospitals attached to the medical colleges in various areas of Punjab, and similarly they're available in the other provinces as well. So since the Standardized machines are available. The cost is 1,450 to 1,500 rupees per test. So at the moment, point of care nested PCR technique is not being looked into at the moment. But I agree with you that the local research organization should take up this task, and they should look into this challenge. And I'm sure if they take up this challenge, this problem can be sorted out.
Thank you. Any more questions from anybody?
Just one comment to Dr. Graham Foster's talk that the real world data from Pakistan, that also shows that in cirrhotic patient, the success rate with soft DECLA and soft DECLA and driver for 24 weeks is more than 91%. And the concern of hepatocellular carcinoma in the people who are suffering from cirrhosis and have been exposed to directly acting agents, even with SVR, is 11.5% as compared to 3.4% in the people who have not been treated. So the concern with hepatocellular carcinoma after the DXY, especially in the cirrhotic patient, is realistic, especially in those patients who are obese and those patients who are suffering from diabetes mellitus. This is a real concern, and the people must be kept under surveillance for HCC development on the standard protocol.
Yeah, I think that's very helpful data to hear the local SVRs. I think we all have slight concerns that the people who come back for the SVR test are more likely to comply. So whilst I think it's very good news, and I certainly think we should be pushing forward with SOFDAC, I think then we just need to know whether we're really getting the high rates and who are the people who are struggling to respond. Your cancer rates have always been a concern with genotype 3. Certainly there are, as you know now, algorithms that say for genotype 3, even without cirrhosis, we should think about screening. So there are real concerns with genotype 3, and with your diabetic population and other cofactors, I really would endorse your strategy of getting these people screened as much as you can. They're clearly at very high risk, and it's disconcerting to hear your very high numbers of hepatocellular carcinoma. That's going to be a real challenge for us, isn't it? And I think we should turn it to advantage and go back to the government and the president and make it clear that if we treat these people now before they've got cirrhosis, we won't be seeing all those cancers. So getting in before they've got cirrhosis for me is really key.
Thank you. There's a question online for Dr. Qureshi. Are age disaggregated stats available for HCV care cascade? Dr. Qureshi?
Yeah, so thank you very much. Yeah, we have the age aggregates for the general population, and then we also have the age aggregates, using the survey figures that we have. We have this information right from year 1 to any age. So we have these figures and these numbers with us, both from the Punjab program and from the national program and the Sindh survey. So the Sindh survey, the Punjab survey, and the national survey, they all have the age aggregates. Thank you.
Can I just ask a question, Dr. Qureshi, also? The surveys that are done on the prevalence of hepatitis, what population is targeted for those surveys?
It was all population. We would go into a house and then we would screen everybody in the house, starting from from day 0 child to any age. So there was no discrimination and no discrimination for even the pregnant mothers, children who were 4 months, 5 months, 6 months. So everybody was screened. So we the only thing was that the Federal Bureau of Statistics would identify the houses, and then we would go in and then screen everybody in the house. Thank you.
So that would give you a true prevalence figure.
Yep.
For
Yes. Yeah.
Excellent. Thank you. Any more questions? Can I, in that case, ask our chairperson, Mr. Naeem Majid, to say a few words, please?
Thank you for the really interesting presentations. Especially, I would like to thank Dr. Nabi Tayyab for highlighting the recent initiatives and activities that the government is doing not only on the curative side, but also on the preventive side. So I posted a question in which I would like to ask again that in the past you have seen that we in Punjab did many mass screening exercises for hepatitis C as well as for Hep B and for other diseases like even HIV and some other disease. So for hepatitis, my question was that should we is such a mass screening recommended for the government, because it is quite costly, when you are screening hundreds of thousands of people on a regular basis. So the first part of the question is that do you recommend such a screening for apparently healthy or asymptomatic people, but probably they are high risk, like jail inmates or the truck drivers who are intravenous drug users, or the people who are frequently going to the barbers for their shaves or that. Because the government has done this, I can see Dr. Huma Qureshi is saying no. So, this was done in the past for 2 or 3 times, and then it was discontinued. So there is criticism on this current government that it was a good initiative of the previous government that such screening was being done. But now this government has discontinued it, so there is a lot of criticism and talk about that it was probably a good thing. So what is your expert opinion that whether this should be done or not, and if not, if it should be done, then what should be the frequency, like once a year, after 2 years, or whatever that frequency should be?
This is correct. Yeah.
Dr. Naeem, let me correct you that the mass screening has never been done. We have been doing surveys. We did a survey in 2008 and Dr. Huma Qureshi conducted that survey. We repeated the survey in 2018 in Punjab, and similarly, a similar kind of survey was done in Sindh, and then a survey was conducted in KPK as well. And roughly again, it was 2018, 2019. And then lots of screenings in the form of camps and all that has been done in the past. Now, with a population of 8.4%, 8.9% suffering hepatitis C, my wishful thinking will be, yes, everybody should be screened in the community. But on the other hand, is this target or is this wish achievable? And then there are lots of other questions which are going to get attached to this. That once we find that this person is HCV antibody positive, do we have the capacity to do PCR on each and every patient? Do we have the funds available to do PCR on each and every patient? In Pakistan, we have a huge population. So we have to do it in a schematic fashion. Microelimination strategy, which has been employed in Ghana, it is a great initiative. It was a great experiment. And the amount of money that we extrapolated after that exercise, that meant that we need 1 billion rupees per district, meaning by if we have 32 districts in just one province. So multiplying it to the other areas, which are even far off, it's going to cost us huge amount of money. So saying that screening of whole population, the wishful thinking is yes, it should be done. But then, is it practical? Is it doable? Possibly right now we need to have a practical approach. We need to first of all link all the patients who are coming to the hospitals, link all the population who are coming to the hospitals to the care centers available in those very places. Once we have achieved that, I've already mentioned the huge gap which is existing, that if with the footprints of 10,000 to 15,000, 20,000 people every day, we are enrolling just 10 patients, 10 new patients per day in the teaching hospital and 3 new patients in the district or tehsil headquarter hospitals, meaning by that we have a huge gap existing there. So possibly we need to invest ourselves better on this side rather than going into the community at this particular stage and getting nowhere and spending more amount of money over there rather than spending more the available money in those areas. We are likely to find more number of patients, and at the same time we need to work more on the preventive strategies and not just on the strategies to identify the patients and treating them there.
Thank you, Dr. Tayyab. Could I ask Professor Afzal to also comment on this, please?
Okay, thank you very much. As Dr. Nabi Tayyab has correctly said, that preventive medicine has to be given a lot of emphasis, especially when there are certain diseases that have definitely vaccination available for them. We are talking about COVID-19 vaccination. As Dr. Hafeez has correctly said, that we are looking for the equitable distribution. However, I think that instead of equitable distribution, we should first deal with acceptability of the vaccine. Even when the vaccines are available, like in EPI program, there are vaccines for hepatitis B. We have vaccine for other diseases like polio, but people are not willing to have vaccination. There is a lot of misinformation that is with those vaccination programs. Either it is for hepatitis B, C, or polio, measles, etc. And now, even with COVID-19, there are many misinformation that is being circulated, and people are really reluctant. As Dr. Hafeez has correctly said, that there are very few side effects that have been reported. Even Pfizer has released their interim results about COVID vaccine, and we have seen that there are no major side effects that has been reported. There are just like anaphylactic reaction, fatigue, fever, headache, etc. So how to deal with the misinformation that is related with the preventive strategies? That is a big challenge. Again, what would be our strategies for prevention? Because most of the people, they are not very much concerned about health. We all know health is wealth. But in reality, a person only knows that there is importance of health when he needs treatment. He has to present to some healthcare facility, hospital, to get the treatment. That is why the hospitals are building day by day, and we are seeing the hospitals of certain specialities that are, it is the public demand actually to build more hospitals, cardiac hospitals, liver hospitals, kidney hospitals, etc., etc. But is this a development? Really, we are looking forward for our finances to be spent on building the hospitals, or we have to deal with our public, with the awareness, with the demand that our people must have that sense that when there is prevention, there is no need of hospitals. Actually, there is no need of building big hospitals and having such a large number of people being admitted in any hospital when you have a very good preventive measures that are in place, and the good systems of vaccination, of chemoprophylaxis, of preventing even through clean water, clean hands, hygiene, all those preventable diseases can be, the burden of the disease, the load of the disease can be decreased by adopting lifestyle modifications and very basic things that is really a need of time, that prevention should be focused. And this is my 2 cents in this discussion.
Thank you very much, Professor Afzal. Thank you for your comments. It remains for me to thank all the presenters at the meeting. Thank you very much for participating, and also the people who have attended it. I hope you've enjoyed the lectures that we organized. Thank you very much, everybody.